Hello, my name's Colin Senior. I'm an orthopaedic surgeon practicing in Dorset, based out of Dorchester. I'm currently the clinical lead in an NHS hospital, but also work at the Circle Hospital in Dorchester called the Winterbourne Hospital. Okay, when someone gets arthritis of the shoulder, they can either present with pain or a loss of function. And as with arthritis everywhere in the body, we advise to follow sort of conservative measures in the first instance. We advise on physiotherapy, lifestyle changes and lifestyle choices, and then finally either painkillers or injections. But unfortunately, some people get to the stage where either the pain is too much or their loss of function is to a degree where they want to consider a joint replacement. And it's the same with a hip and knee replacement. We now have shoulder replacements that have been on the market and we've been using now for a number of years. So when someone comes to see me regarding wanting or needing a shoulder replacement, I have to go through a number of series of investigations looking at both their bone quality and also the soft tissue structures around the shoulder, which with a shoulder, as opposed to a hip and knee, are extremely important. And the reason being is that there are different types of shoulder replacements we use for different types of shoulder pain and conditions. For example, if you're younger, when we've got good quality muscles and tendons that are still attached to the shoulder joint, and I'll show you here on my model, we tend to go for a shoulder replacement that makes use of these tendons. So we tend to just use a like-for-like replacement. So we replace the ball section with a ball, and the socket section deep inside the shoulder with a socket. And these two bits of the component link together and the shoulder moves. For this to work well, you need all the tendons around the shoulder to be working. And this tended to be the mainstay of shoulder replacements for a number of years. This obviously doesn't work very well for people with damage to the tendons, which can happen as you become a little bit older and with age. So approximately 15 years ago, we came up with a different type of shoulder replacement, which we call a reverse shoulder replacement. And this sort of bypasses or doesn't require the need of the tendons to get good function or to obtain good function. So instead of having a ball, place the ball in the socket with the socket, we convert this around. So we turn this or invert it or reverse it on itself. And we have a system similar to this. So this is now the socket of the shoulder, and this bit is the ball. By doing so, this changes the positioning of the shoulder when we place it into the human body. And it uses the other muscles that are still present in the shoulder to gain control and movement. So we have two main types currently on the market that we use in different scenarios. So when I see a patient in the first instance, I talk this through, I assess the shoulder functionally, and also perform some investigations. So all major surgery carries small risks. That's the same with any operation around the body, and particularly orthopaedic surgery. Now we try and minimize those risks as much as possible. But unfortunately, all operations do carry tiny risks. So they split these risks into two parts. Firstly, we have the anesthetic risks. In regards to having a shoulder replacement, you tend to have this under a general anesthetic. So there are increased pressure and strains on the heart and the lung, which is usually covered or explained to you by one of my anaesthetists. But you also have risks of the surgery per se. And as with all big joint replacements, the two main risks that we particularly worry about are firstly infection and secondly blood clots. Now, luckily in the UK, that tends to be in less than 1% of all big joint replacements, including shoulder replacements. And there are certain things that we try and instigate or plan to try and reduce that figure further. There are other less of a worry in risks that we as surgeons, we still worry about, and we still explain this to a patient when I see them. And these include bleeding, nerve injury, a small risk of dislocation. And then finally, all major joint replacements have the possibility of wearing out with time. Now, with the shoulder, we find with current data is suggesting that shoulders tend not to wear out as quicker as say, for example, a knee replacement. So we're looking at maybe lasting at least 15 years or so. There is obviously a small risk currently of catching COVID into all hospitals, but both private and NHS hospitals have certain quite strict criteria in place to reduce this risk quite substantially. So shoulder replacements have a probably near 100% chance of getting rid of pain, or the arthritic pain that people were experiencing. The difference with a shoulder replacement as opposed to, say, for example, a knee and a hip replacement is that we're relying quite heavily on the muscles and the tendons around the shoulder. So I never tell patients that they're going to gain a range of movement which would be comparable with what they had prior to their shoulder becoming painful. Having said that, I'm surprised a lot of the times that people do sort of go beyond my expectations and get an improved range of movement that I wasn't expecting. But usually patients' range of movement is up to sort of shoulder height. And then with my physios, we work on gaining improved movement with the use of the scapula, which sits behind the shoulder. But on the whole, the shoulder has a very good chance, the shoulder replacement has a very good chance of getting rid of pain and improving function, but it's never really going to be 100% movement compared to the other side. So when you come in for a shoulder replacement, you'd be surprised how quickly you'll be out of hospital. And usually a lot of my patients are in hospital for a day or max 48 hours. And the reason we can get you out and about and up and about and using the shoulder quite quickly is that it's an upper limb joint replacement. So you're walking quite quickly, obviously, because we're operating on the upper part of the body. We try and get the shoulder moving very quickly as well now. Instead of sort of staying in a sling for long periods of time, we try and encourage our physios to try some gentle movement right from day one. All wounds take approximately 10 to 14 days to heal, but in that time we do encourage movement. It's just within limits. And then from 2 weeks, we really start to push it a little bit more, letting the shoulder bed in before we really start working the shoulder at six weeks or so. Most people actually are back to doing light duties around the house or even back to sort of computer work and the phone within a couple of days after the operation, but it can take a little bit longer before you're back to more manual or physical activities.